Welcome back to another episode of the Brawn Body Health and Fitness Podcast. Joining me today is Dr. Gerard Gioia from Children's National. Gerry and I are going to be discussing concussion management in addition to what he calls the developmental readiness model, what that means, what that looks like, and possibly what the next evolution of concussion care and management looks like. This is a great episode, very informative, and I highly, highly recommend you check out everything that Gerry is doing, especially his research work. This episode and every episode in season 5 is sponsored by ISOFIT, my go-to for all things isometric strength training. For more on ISOFIT, you can check the description below. Enjoy. Gerry, welcome to the podcast. I'm super excited to work with you today. Thank you so much for being here.
Hey, my pleasure, Dan. Absolutely.
For people who might not be familiar with you and all the incredible work you've done on concussions over the past several decades, this is probably painful for me to admit on your behalf, but longer than I've been alive, Gerry. Would you mind? I know, it's crazy. Would you mind filling them in a little bit about who you are and all the amazing things that you have done?
So I'm trained as a pediatric neuropsychologist. And people wonder what that is. I say, one of my feet sits in sort of the neurology world, the brain world, and the other sits in the psychology, kind of cognition, behavior, emotion, social side of things. And my job is to really, understand kids when there have been certain issues that have affected their brain functioning and how that plays out in their lives, thinking, learning, relating, all that sort of thing. And so as a pediatric neuropsychologist, over the number of decades that I've been doing this, I have worked with a number of different populations, including kids with more severe traumatic brain injury, as we refer to TBI. And over kind of that time, we began to recognize that kids with less severe injuries, though not necessarily any less consequential effects, needed better sort of definition and understanding. As a clinician, I get to see these families, these kids, hear what challenges they have. And having started this work back in the 80s, we realized that we really did not have good ways to assess them, understand them, diagnose them. And so my research hat sort of came on with my clinician hat. And I really started to embark on developing better measures of various aspects of their, of kids functioning. And it started out with this whole area of executive functioning, which is kind of how kids self-manage and learn to do that across development, organize themselves, plan out things, be able to kind of hold things online as they strategically sort of solve problems, be able to kind of inhibit or stop, these tendencies and impulses along the way, and then really take stock and monitor what they're doing, make sure they're kind of on their path. So we got involved in that. But then again, as the mild traumatic brain injury, as we have kind of clumsily called it, we realized that that was a whole other group that needed different kinds of measures, and then got sort of connected with the CDC, the Centers for Disease Control and Prevention, their injury center, and have worked with some really great folks there. Have gotten a number of different grants from them to really help develop these assessment and treatment tools, as well as even some community education materials. And again, with my focus being largely on kids and adolescents. So that really kind of snowballed over the years. Gosh, I guess we've developed probably close to, 8 to 10 different measures over time, but because of need, I had no intent to go out and just build something without any reason to it. So, and I can get into more details on those kinds of things. But the field has really evolved. When we started this in the early 2000s with concussion or mild TBI, most of the work was really focused on adults, as is often the case. In the early 2000s, we began to identify that players from the NFL were having some challenges, and there had been some protocols that had been established. And then we started to see this in collegiate kids, high school kids, and then going down into the younger ages. But still, we were having some challenges, both defining the nature of the problem in younger kids, and also getting the message out to families, to parents, to schools, to primary care physicians, to emergency departments. And that's where really being able to partner with the CDC was critically important. And I began to work with them on their heads up materials. And for those who are not familiar with that, if you go to cdc.gov/heads up, it is a library of materials on concussion for, again, what I call the four corners of a kid's life: their medical system, their family, the school, and then their kind of sports recreation world. And there's materials built in for all of those, all those various aspects of a child's life. And so from there, again, we realized that if the community is not well informed about this injury, then kids are going to be put at risk. And that then advanced us into the whole legislative process. There was, a number of unfortunate situations where kids had gotten really hurt, and the one that was featured probably most significantly or more prominently was Zachary Lystet in the state of Washington. And he's a kid that was an 8th grade football player who had a more severe injury because coaches, kids, parents, nobody knew that, he should be pulled out of the game. And my good friend and colleague, Stan Herring, who's a sports medicine physician and a physiatrist up at University of Washington, really went on a public health campaign to educate people about how to recognize these injuries. And as Stan said, I realized that I wanted people to learn about this, and so we would set up all these talks, and nobody came. He said it was really disheartening. So they started to look at maybe it was important to systematize this more, and they went to the state legislature and said, we really ought to build these education programs and then this law to remove kids if we suspect. And so that whole process began, and we began this whole national effort to pass these, what they call the Lystet laws, which is that, sort of the when in doubt, sit them out. If a coach or a teammate recognizes that something's not right with that person, they really need to come out of the game and can't go back in until they're cleared by an appropriately trained medical provider. So that whole process really exploded, and it was actually an amazing public health effort, because from 2009, when the state of Washington passed their law, over the next 5 years, we passed laws in every state in the country, including DC. So now there are these, what they call return to play laws going on. But again, we still have a pretty significant need for public health education. We now have better tools. The international conferences, as well as the CDC, have put out a set of guidelines for healthcare providers on how to diagnose and treat and manage it. So we've come a long, long way in 20 years. But we still have a ways to go, and having the opportunity to work with folks like yourself, where we now know that an active treatment process is important. No longer do we just sit them down and do nothing. As I say, rest is a 4-letter word in concussion management. We don't want to do that. And so having programs like yours, where we can send kids to get activated to address issues of balance, vestibular dysfunction, under activation, we would get them aerobically moving, is really, really important. So I'm obviously going on and on and on, and you want to ask me more questions, but the point is, we really evolved from a very passive understanding, a passive practice, to a much more active system at this point.
Yeah, no, definitely. I think you bring up so many amazing points. And just to kind of recap here a little bit on the historical side, it is crazy to like stop, think, and look back about how far we've come over the past several decades. And that's largely credit to work of amazing individuals such as yourself, Gerry. I mean, plain and simple, to think about where we were historically 30, 40, 50 years ago, not really understanding
Yeah,
concussion at all, to the
yeah,
point where now we understand that it can have so many various ramifications, and we kind of, or at least I kind of classify them into a few different buckets, right? As you mentioned, maybe it's more of a vestibular type of concussion and it impacts things from more of a vestibular standpoint. Maybe it's more of an ocular standpoint, or maybe it's even like a blend of the two of them and it's more of a VOR combo. I've also seen some that kind of fall into like more of like a headache or like a
yeah,
post-traumatic migraine type of bucket.
yeah.
And so on that way. I mean, I'll even make the argument for like a parasympathetic type of bucket as well, like an imbalance
Mhm.
between the sympathetic and parasympathetic system. And I
Yeah,
think
yeah,
historically, we didn't really understand that, what many just kind of view as a little hit to the head or someone got their bell rung could have
right.
so many various ramifications from a more like intricate neurologic level on how the body functions.
Yeah, and I think just as general neuroscience has advanced, it's really helped us to better define what is happening and really to in some ways almost subtype these particular manifestations. To build on the subtypes that you mentioned, we also have the cognitive subtype. Where kids are just not able to concentrate, focus, remember, organize, as well, or some of the emotional kinds of issues that go along with it. I mean, what's interesting about the emotional side is that we see both primary emotional issues, that is, somebody's so much more irritable or so much more kind of emotionally reactive to situations. Um, but then you also have the secondary piece, which is that, I'm not with my friends as much. I'm not doing my sports, or I'm not, actively, engaged. I'm having troubles with learning. I'm overwhelmed with what I'm getting. And so now the secondary kind of anxiety or sometimes mood effects here. And one big area that I think we all deal with, regardless of the subtype, is the sleep factor, and sleep being disrupted as well. And that has its, implications for all those other areas. So yeah, it's really important that when someone is identified with a concussion, we really begin to look at in what ways is it manifesting, and then really target those areas for treatment. Good news is that, the majority of kids have a fairly regular recovery. And the big study out of Canada that I was involved in, the 5P study, showed that, probably 70 to 80% of kids are recovering pretty well in those first, 2 to 4 weeks, after the injury. And then there's the group, that 20 or 30% where we need to do much more targeted interventions, where folks like yourself, where we have, psychotherapists, where we have educators kind of working with them, where we have, a tutor sometimes, or other kind of cognitive, assists, where we really need to now more formally bring them into a more specific treatment protocol. So again, it's we've advanced and really begun to look at this as not, one concussion is not like the next one, as my good friend Kevin Guskowitz says. They're like snowflakes. No one is the same, and so it's important to kind of individualize each child, each kid, each adult, and target what they need.
Yeah, I completely agree. And I mean, I can't echo your point on the importance of an accurate assessment and accurate subtyping
Yeah,
enough. And again, as we mentioned, a lot of those various, post-concussive symptoms, or however we want to like term that, a lot of people didn't recognize those in the past. And I think
right.
echoing your point on the importance of collaboration and care, when it comes to someone who's sustained a concussion. I think that is probably one of the most essential pieces. I think that's something that still to this day could be improved upon. And I'm probably guilty of that myself, right? Like the more we all work together to best provide for the person in front of us in the school, in the sports setting, from a neuropsych standpoint, from a physical therapy standpoint, from getting the athletic trainers involved and the coaches involved and so on that way. Like the
Yeah,
more we can all work together on the common goal of getting the person in front of us back to where they want to be and back where they should be, I think the better we can often provide for them. And
yeah,
echoing your
yeah,
point as well on the advancements, from a rehabilitation standpoint, I think it's so refreshing to hear someone such as yourself emphasize active rehab and active process to recovery instead of just, hey, sit in the dark room with the lights off and,
yeah,
don't come out at all. Because I think historically that was the general advice that was given to a lot of people.
yeah,
Don't be
yep,
around people, isolate
yep.
yourself, avoid light, avoid stimulating situations. When we stop and think about it, that's life in America in today's day and age. It's bright, especially if you're in the city. Like you said, you're in New York City earlier this week, and that's the city that never sleeps, right? So
That's right.
it's important to get people into those more active, engaging environments because that's more conducive of life. It's just maybe, the step 1 to step 100 from going from dark room and isolated at step 1 to normal life at level 100 needs to be kind of bridged. Like that gap needs to be bridged with little checkpoints along the way,
Yeah, yeah,
instead of jumping from one end of the spectrum to the next.
yeah, yeah. And the interesting thing when we think about the mild TBI spectrum or side of the spectrum, concussion, it's probably 9 to 1 of mild to sort of the moderate severe, meaning that you know these are individuals who are sort of the walking wounded. They are out in the communities, and again, historically, we didn't recognize that, and folks really struggled. And one of the things that I firmly believed, a number of years ago, was that there aren't enough specialists to sort of initially see these individuals, again, be they kids, adolescents, adults. And so we began to work very carefully with the primary care world, and still are. Make sure that, first of all, pediatricians know their kids. They follow them annually, and sometimes even more frequently. Kids that play sports need to come in for sports physicals or some type of medical assessment. And what we have tried to do is to say, you as a pediatrician are the ones that know these kids the best and the families the best. And in many ways, you should be the first point of care. Most kids don't need to go to the emergency room for these injuries. There are some indications for that, but most kids don't. And so we really have worked hard, and this was part of our effort back in 2007 when we developed the Acute Concussion Evaluation, or the ACE, with the CDC, and it was part of the what was called at that time the physician's toolkit, now called the healthcare provider toolkit, to give kind of a nice systematic way for the primary care folks to identify these potential injuries and diagnose them and start at least a process of management. And I think from that perspective, it's gone fairly well. I mean, in our clinics were bubbling over because nobody was able to see these kids, and so we had some delays in getting kids in because of that. But as the community has been more and more, and by community I mean the community of primary care physicians have been more and more educated about this, now have tools to help guide them. Families can go to their natural place, to my doctor down the street. What we still are working on, though, is to help them understand that that active rehabilitation model is necessary. So we're still hearing, kids that are being told, "Don't go to school until your headaches are gone." Don't go out and do physical activity. Really kind of isolate yourself. And so over the years, as these things kind of continued, I put together a set of talks, and I call them the 8 Great Questions, on concussion management. And really, they're taking those kinds of issues that we are still seeing in the community when kids get referred to us, parents saying, well, my kid was actually this morning, we had a kid whose primary care physician said, I don't want you to go to school until you get into the specialty clinic. So she's been out of school for 2 weeks because I wasn't here last week. I was in New York City, and so I couldn't see her, within that first week. And that's not good for her to be out. In fact, she came in really stressed because she was behind in her work, and so far there had been no adjustments made to that. And so it's kind of like, well, no, you can go back to school. You can be active, you can do things. So we're still working. We've made some very good successes in sort of the diagnosis and the early diagnosis in the primary care world. And now we're really trying to work on what are those treatments that they can also recommend that are everyday treatments, going back to school, but doing it in a careful way, getting out, taking walks during the day. Sunlight may bother you, loud noises may bother you. We'll manage that. You don't totally turn it off, but you manage it carefully. Make sure you're hydrating well, you're getting good sleep, that you're eating 3 meals a day, and that you're getting some social interaction with your friends. All those things are so important to recovery, because when you feel isolated and not able to do things, that has its secondary effects, as we mentioned before. So
Yeah, I completely agree. And I think, every patient I've seen from you, and when I spent a day shadowing you in the clinic there, I think almost everyone I saw, you gave recommendations of prioritizing sleep,
yeah.
drinking enough water, which it's amazing how many people don't drink enough water. And I
I
think you
know.
gave the same
I
exercise
give
type
him
of,
my
yeah, the same type of exercise recommendations to everyone, right? I think
yeah.
you said something about at least 30 to 60 minutes a day of walking. And it's
Mm.
not just like moving around the house or moving around the school, but like actual, like
Get the heart
purposeful,
rate
like
up. Yeah.
movement. Yeah. And I
Yeah.
think that goes into the subtyping that we talked about before. I mean, basic aerobic exercise is going to benefit, I would say, almost all of those subtypes, if not all of them. I mean,
Yeah.
plain and simple, let's pick, your parasympathetic bucket, for example. Like, we need to stimulate a heart rate response in order to cause adaptation from a neurological level. And even if we pick something different, like, say, your emotional or cognitive bucket that way, plain and simple, I think the endorphin response that we get from exercise and the way people feel after they've done something, physically active,
Yeah.
cannot be overlooked.
Right.
And if we start to restrict that and continue to restrict that, and then we stop and wonder why kids aren't improving, we kind of have to stop
Yeah.
and look at ourselves and say, well, what have we been doing and how can we, better provide and learn from it? And to that point as well, I think that's where the importance of all those assessments that you developed, that you talked about earlier, when we started, come into play as well. Is, we need to, if we're going to intervene with something, we need to be able to actually assess what that's doing to someone. If
Hmm.
we can't see objective change or, subjective difference, then how do we know what we're doing is actually having any benefit, right?
Yeah.
Like,
Yeah.
I think you developed, or definitely had a heavy hand in something called a Cheers
Yeah.
outcome
The cheers.
survey.
Yeah. Yeah.
And that's one that I've started to use, like, literally with every patient that I have at the clinic. They fill it out at the start of the session and they fill it out at the end of the session. And I kind of look at that and I say, did I do enough to provoke symptoms? Because with
Right.
concussion and rehab, we actually want to provoke the symptoms.
Yeah.
Did we do enough? Did we do too much? Do we
Right.
need to do more? How does that trend over time? And I think that having that, like, objective data really helps steer us, or helps us know if we're going in the right direction for someone's recovery.
Yeah. The cheers was something that, gosh, it was probably about 15, I don't know, maybe even close to 20 years ago. We were just, as clinicians, you would recognize, as families and kids would say, when I try to read a book for too long, my headache starts getting worse, or if I overdo it, running, down the street, whatever, I get so over fatigued. And so we started to think, what would be some of the key symptoms we would want to monitor? And we thought, well, headache is a big one, fatigue is a big one. And so we tried to catch each of the categories, concentration, and then irritability. Those were the initial four. But then we also realized that, dizziness was important to look at, because certainly that vestibular element, but also just the safety element for kids. And then some of the sensitivities to, the environmental stimulation like light. And then ultimately, I kind of like, we built into it the fogginess thing, that kind of difficulty thinking clearly, because concentration didn't always address that issue, but kids definitely got more, foggy or fuzzy or, kind of lack of clarity in their thinking. And I remember I was literally driving through the roads of Pennsylvania talking to one of my staff members, and I said, what we need to do is to come up with a system where, at the beginning of a session, we do this assessment of those 7 symptoms. And at the end, we do an assessment and we see to what extent we're provoking these things. And that can be done with physical activity, that can be done with cognitive activity, like school. And so to do that from a metric point of view, a psychometric point of view, you really need to look at what's called base rates. You need to look at what's the level that these symptoms change without any injury situation, sort of the base level of change. So you bring a kid into an afternoon session and you give them some cognitive tests. And does it provoke headaches? Well, rarely does it provoke headaches in kids. Does it provoke a little bit of fatigue? Yeah, there's a little bit of fatigue because, they get a little bit more tired. Does it affect their concentration? Yeah, maybe to some extent. Does it make them more irritable? Well, maybe so, because they don't want to be there. Anyway, so what we did is we back in the days when we used to do a lot of baseline testing of kids, so these are kids without injuries, we actually gave them the before and the after symptoms, and we could see what's that variability in those scores. And we found that with the 4-item cheers, that it normally you would see an increase of about anywhere from 0 to 3 points, normally without an injury. And so we were able to establish with our statistics that a score of 4 or more was beyond what would be typically seen. When we added the 3 additional symptoms, we then again looked at that same issue, and what we found is that anything above 6, or really 7 and above, was beyond that. So we were able to establish, with good evidence, kind of what is the normal degree of variability of those kind of symptom reports and what was beyond that at a clinical level. And that then allows us to really, in our clinics here and what you're doing and what others are doing, to kind of look at what are those exertional effects, as we refer to them. So it's the CHEERS is the Children's Exertional Effects Rating Scale. You always got to come up with a good acronym, right? And so the ACE, the CHEERS, the class. So we wanted to, again, not just say, yeah, they seem to go up a little bit. Yeah, we wanted to have some good scientific evidence for a clinically significant change. And then, of course, as you say, we also then want to see, can we see that begin to improve over time as our treatments come in? Because most of us, again, maybe you get a little bit of fatigue, whatever. Most of us don't have these major spikes in this kind of a symptomatology without some good reason. So again, it's a good monitoring tool. I always get excited when you're seeing our kids and you send those cheers over to me. I can really look at them and go, oh yeah, that's interesting, and yeah, they're starting to come back under control. So again, those are the kinds of things that really, in many ways, the patients are the ones teaching us what we need to do to then help them. This wasn't something we just sort of cooked up out of the sky. It was really based on, what our observations were clinically.
Yeah, I love that point. And I mean, going off of that as well, I'm very opinionated on this, but I think from a rehabilitation standpoint or PT standpoint, I only see my patients who have sustained concussions in a one-on-one setting.
Mhm.
So I'm with them for a minimum of 45 minutes. And I know, that's not like the standard in the PT rehab world, but I really think that's the way it should be, because if we aren't there to actually observe and have conversations with them about how they're doing subjectively, then how are
Yeah,
we going to know what we're doing, like what effect it's having, right?
yeah,
Like if
yeah,
we just
yeah.
give someone the same 10 to 15 VOR1, VOR2 type progression, but we don't actually sit there and see how they're doing it, see how many breaks they take, talk
Yeah,
with them
yeah.
during it, then how do we actually know what we're doing and what effect it's having? And on that point too, I think the rehab has to be progressive. I think a lot of times clinicians get caught up in this, well, I can just write 10 exercises down on a piece of paper. People will do those 10 for the next 3 weeks and it'll, improve. And maybe it improves, but maybe it doesn't get us to the finish line. Yeah, maybe we get 50% better or 60% better. But what about that second half, right? Like
Yeah.
we need to progress beyond the VOR1, the VOR2 progressions. They're great, but there's a certain time, especially as you mentioned, you like to work with a lot of younger athletes. Well, with the younger athletic population, if I think about what's going on when they're on a field, I don't care if it's football, lacrosse, soccer, what sport it is, they have to be constantly aware of the space on the field, their teammates, their opponents, the ball. There's probably going to be a lot of background noise, or there could be a lot of background noise. Lighting, maybe it's at night, maybe
Mhm.
it's, middle of summer and super bright. Like there's so many different factors and variables and considerations that go into
Yeah.
play from the athletic standpoint and what the brain actually has to do when an athlete's on the field, that unfortunately VOR1 progression is not going to take them there. We have
Mhm.
to get into something a little bit more advanced, but as
Yeah.
we mentioned before, we have to progress to it. We can't just jump right into it overnight. We have to slowly build up to it.
You know, I will also give credit where credit is due. The model that we came up with, and the tracking sheets for physical activity are really an adaptation of what Isabelle Gagnon, who is a physical therapist at Montreal Children's, put together back in 2009. They wrote a paper showing kind of their rehabilitation model. And interestingly, at the same time, John Leddy at University of Buffalo, who's a good friend and colleague and also New York Giants fan with me, is was looking very similarly at how to activate. And of course, they had their Buffalo treadmill test that they developed, and so it really they were both coming at the same problem. And I remember looking at the two papers they had written back then. I think it was 2010 were the papers, and saying these are very similar models. Isabel's applied a little bit more to kids, and a little bit more of a practical model. She used more of this, logging of response. And John, a much more, scientifically, they're both scientific, but John certainly used his treadmill test, and he looked a little bit more specifically at, again, that response to that, but really with the same underlying model. How do we progress somebody, and monitor that, give them the feedback, you're doing better, you're going, really help to build their confidence in what they're doing, and to develop a home program. So it's not just a 2 times a week sort of thing when I come into the clinic. It's I am going to do this, throughout the week. And again, whether it's an ocular motor test, whether it's a aerobic test, whether I'm doing something to strengthen, it's what I'm doing, and regularly doing. And I tell kids, I say, you got to do this most days of the week. I mean, if you had strep throat and you go into your doctor and he says, well, I'm going to give you this antibiotic, do you only take it 2 times a week? No, because it wouldn't be very effective. You need to be doing this in a regular way. You are increasing these important chemicals in your body that are actually helping you, whether it's the endorphins or whether it's excuse me, what we call brain-derived neurotrophic factor, or BDNF, which seems to be a really important internal chemical that helps with these recovery factors. And so, I think that both John Leddy and Isabelle Gagnon really hit on something very early. And then, more and more and more of us started to use that model and see that it had benefits. Plus, imagine you have a kid who's pretty active to begin with, and then you shut them down. Well, they're not real happy about that. When I tell them, I want to get you active, they're like, oh, yes, good. I said, but, there's the not too much, not too little principle, okay? I don't want you doing so much that you're going to blow up your symptoms, but I also don't want you sitting on the couch anymore. We got to get active. We got to do this in a daily sort of way. So I give big credit to the physical therapy world and really helping us to move this whole process forward. And then John in sports medicine also doing that.
Awesome. Yeah, no, for sure. And again, that's the importance of collaboration, right? All
Yeah,
of us
yeah,
working together. And
yeah,
I think you and I have talked about this in the past with I think you called it like a developmental readiness model for youth sports, where essentially we look at not just the physical component of the athlete or the person in front of us, but we look at things from like an emotional, cognitive, behavioral, and
yeah.
using that as a way to like determine engagement in youth sport. And I don't remember all the details about our past conversations about that, but would you mind filling us in a little bit more about that proposed like developmental model
Yeah. Well,
moving forward?
so let me just first start out by saying that we've gotten a little silly in our way of thinking about human beings. There's the physical side, and then there's the psychological side, and the two shall never meet. Well, that's a bunch of baloney, right? I mean, if I am doing well, as a healthy person in my exercise program, that's exciting. Well, guess what? You just activated emotion. Imagine that. And that's a motivating factor there. When you think about your, whether it's an exercise program or you think about how you're going to fit that into your day, cognitively, you've got to bring that in and you got to think strategically. Well, geez, it's a weekend and I have this amount of time. It's a weekday. I only have this amount of time. I got the kids do this, or I got to, do these activities. All of that works together. And so this whole developmental readiness model began probably about 2+ years ago. First of all, as a pediatric person, we work with developmental differences, all the time. I can have a 6-year-old and I can have a 16-year-old. Well, I'm not going to treat them the same way because we know that physically, cognitively, socially, emotionally, whatever, they're all different. Their lives are different in school, with friends, all that sort of thing. And so as pediatric practitioners, that is a template that's built into us to sort of know that there's developmental differences. Well, and we then apply that to sort of the world of youth sport. What we do in introducing a 7-year-old to any sport, and I don't care what it is, whether it's contact or non-contact, we need to put it at their level. About, I guess, 12, 13 years ago, the American development model was introduced to youth sports. Ice hockey was the first one in the United States to adopt it, USA Hockey. And what they recognized is that they wanted more kids to engage in ice hockey. But if you think about a 6 or 7-year-old, maybe even an 8-year-old who's just, kind of learning to skate, and they are at one end of the rink and they look up and see the other end of the rink, that's a long ways away. And to be able to play a meaningful game where now I have to skate that far, I have to be able to hit the puck and pass it and do that in a meaningful way, that just seemed a little beyond their capabilities. And so what the hockey world did was to then turn the rink sideways. And basically now we have a rink that is roughly about a third of the size. And now it's a much more manageable amount of real estate. They started to move players around in different positions so they could really experience the game more broadly. They actually measured and saw that kids had more touches on the puck. And the satisfaction just went up. And it made sense because, you are taking a kid's developmental skill set into account, and you're then managing the game along that way. Tennis was the next one to do that. They recognized that, for any young kid, the net was basically up to their eyeballs. The racket was big. So we needed to manage those, physical features. And the USTA has really been very active in that process. And then soccer began, and then, and so I was involved in the development of what we call the football development model, or FDM. And with FDM, what we, recognize is that there's different types of games of football. Flag football has now really taken off. And we thought, for young kids, probably starting them out with tackle football is not a wise thing. Get them engaged in flag football, and it's basically keep away. And, it's a fun sort of game in that regard. It brings girls into it much more actively. In fact, it's a hugely developing sport now with girls and women. And then you get sort of the flow of the game, right? And then you can move into what's called modified tackle, which is a smaller set of, again, kind of like hockey, smaller set of players in a smaller field. And then you can move ultimately into the full game. And so, as I say, we developed a curriculum for that sport to both enter and to progress in. The challenge with all these sports, though, is how can we know for any given child where they might fit into that sport? Certainly in football, we believe that all kids should probably start out in flag. But what are the requirements of that? And how can we make sure they're having fun and that we are gearing the game to their level? So for example, with flag with younger kids, I think you want to have a smaller field. You may decide on the number of players that you want to have. It might be different from older flag. It's really, you want to gear it again more appropriately. And so the whole idea about developmental readiness is, okay, we have the curriculum set up. Now we need to understand, what is that child ready for? And again, I'm going to go back. It's not just their physical readiness, but how do they understand the game from a cognitive perspective, from a strategy perspective? How do they kind of manage their emotions in a competitive situation? A kid pulls your flag, a kid steals the puck, a kid slams the tennis ball, over the net at you. How do you manage that? Well, you want to build that into a coaching model so that you help kids, sort of build those skills, resiliently. But you also want to know where the starting point is. So the whole idea behind developmental readiness, that we have an active team now building a research protocol, is that we want to take these sports and we want to break down the curriculum, but we also want to know how kids fit into that curriculum. And I use a reading example all the time. We have a great reading curriculum in our schools, and kids come in at, kindergarten, maybe even preschool, and you want to know what skills do they have to connect appropriately with that reading curriculum. Some kids are advanced, some kids are right on target, some kids are a bit, lower in their skill set. You want to make sure that you are targeting them appropriately to the curriculum, or they're going to get turned off to the act of reading. Same thing with sports. If I am not capable of, doing certain things within that sport, I'm not going to be interested. I'm going to drop out. And so there are benefits to a better matching of that person's developmental readiness. And so what we are doing right now in football is we have a team that is basically taking the act of tackling and blocking and sort of deconstructing it and looking at what are the developmental requirements to do this both effectively and safely. And then in any given child, we want to develop these screening tools that will allow us to say, yeah, your child is ready for this level, and this is where we think they would be best placed. And then we build a coaching model to say, yeah, at that level, here are the skill sets you're working on, both physically, cognitively, strategy wise. I sort of say it's the Patrick Mahomes effect. I know that in this situation, I need to be strategic in this way. And then, how do I also manage my behavior, my emotions? And then the social part, which is the team aspect. Are we making sure that we are focused on team concept, working together, all the really critical life lesson skills here? So, it's a big project. It's quite lofty in its expectations, but I think it's ultimately going to be beneficial in two major ways. Number one, again, satisfaction, because I'm at the level that I can attain good performance. But then injury management, injury reduction, because I'm not overmatched and doing things that I'm not capable of that can potentially hurt me. And again, in the contact sport, we think about the head, the neck, the muscles, taking hard hits. But in the non-contact sports, we think about how maybe somebody blows by on a tennis court, and you're just like, you don't even know how to move. You're not capable of doing that. Well, that's not a satisfying thing to be, to lose, 40 love every match. So anyways, I think that, again, what it's doing is it's building, development into the sports, and better matching kids. So that's sort of the model. And, right now we have, groups that are saying, well, in the game of football, they shouldn't start until they're, 12 or over, or 14 or over. And I know there's good intent around kind of some starting point, but we know that there's wide variability in development. And a 12-year-old is not necessarily a 12-year-old is not necessarily a 12-year-old. I mean, when I was in junior high school, as a 12, 13-year-old, was about the size I am right now. My brother was about half my size when he was this age, and my age in middle school. And it was, we would have matched very differently in sports. And so it's really important to be able to, fit that properly, so that not only do I have a good sports experience, but he's got a good sports experience because he's better matched with the level that he can attain, some fun and performance in. So that's kind of the general model that we're working toward. And again, from my perspective, it's both injury prevention, and I'm interested in head injury prevention, but I'm also interested in really promoting kids' physical activity, teamwork, ultimately sort of that life skill that is going to, from a public health perspective, really help kind of the health of people physically and mentally from a lifelong experience.
I think that's a huge point, and a great one to kind of wrap up on is, I think a lot of people, they kind of fear some of these head injuries and concussions, and they say, well, how can I completely prevent them? And, are we okay to still do sport, even if someone had a concussion like 5 years ago, or that sort of thing? And I think it's important to note, at least in my personal opinion, that the benefits of sport and exercise and activity far outweigh the risks of one possible head injury. Now, there are cases that develop. There's always going to be a case that develops that, hey, someone's had a history of like 6 concussions or something extreme in a very short amount of time. And we have to kind of step back and reassess and individualize things a little bit. But I think in general, physical activity and engagement in recreational sport is safe. And even with the possible risk of head injury, and again, even with advancements like the development model that you're working on, I don't think it's ever going to get to the point where we prevent 100% of injuries. It would be great if we could, but I don't think it's possible to prevent 100% unless we just don't engage in anything. And I don't think that's really an option. So I think being pro-involved, but smart about how we do it, is certainly the way forward, in my opinion.
Yeah, absolutely. I mean, again, coming at this originally from the concussion perspective, I think that better matching, better coaching, better, game management will absolutely reduce. But, things do happen. But that's the other side of it. If we better recognize, and pull somebody off the field, they will not have, those repetitive injuries. They will not have, that the worse outcome. And the other side of it too, even before all these models are put in place, there's actually some pretty good epidemiological, meaning large group studies that demonstrate exactly what you're saying, the benefits, of sports and how they, even collision sports, and how they outweigh the risks. But we can always improve. And again, as a developmentally, based person, a pediatric person, I think we have to more explicitly take this into account, build that into our sort of sport mentality, so that we say, okay, we see that your child has, these great characteristics, and that fits them in right here into the curriculum. Let's start them out at this level. And at that level, we have coaches who know how to then really promote, those physical, those cognitive, those social elements. Amanda Visek, who's a really neat researcher at GW, has looked at the elements of fun in sports. And her original premise for that research was the fact that kids, drop out of sports in mass numbers. Close to 70% of kids drop out between the ages of 11 and 13. And the number one reason is it's not fun anymore. I'm just not getting the enjoyment out of this. And to me, I think a major part of that is the mismatch of the person and the sport. As part of that, I think it's also that we're not building the coaching curriculum in a way, but we're also not matching the kids in that way. And again, if we can bring this model together, and not only enter the kids and progress them as they can handle it, but also help the adults who are teaching them, coaching them, then I think we're going to have a much more fun, if you will, youth sports experience that will then live on.
Yeah,
so
I completely agree. I love that. Gerry, for people listening who want to find out more about you or check out your research work and all the incredible stuff that you continue to do, where can they find you at? Are you a online guy? Have you entered the age of like Instagram and TikTok or?
Well, I do have an Instagram account, but it's fairly very quiet. I mean, email is probably the best way right now. Just touching base with me, and I'm happy. I'm on LinkedIn, but that's my big foray into the world of it all. But no, my ggioia@childrensnational.org is my email, and be happy to field questions or thoughts about any of this as the audience may want.
For sure. We'll link to that in the description below. That way, if you didn't quite catch it, you can just click there and keep up to date with everything that Gerry's up to. Really appreciate your time today. It was great to catch up and talk about all these amazing things.
Yeah, thanks, Dan. Also appreciate the invitation too.